Patient 67, please come in.
Hi, Dr. Su. My daughter's posture has been very strange lately. Look at her right shoulder. Doesn't it seem consistently higher than the left?
Oh yes, I see an uneven shoulder. How long has this been going on?
Oh well, at first I think she's just lounging, but recently when she bent over, I saw a scary lump protruding on her right back.
It's about 1 year ago.
About a year ago, my shoulders and back started feeling a bit stiff during dance practice, and gradually I noticed my waist and back were sticking out.
Thank you for sharing that, Maya. What you're describing points toward the adolescent idiopathic scoliosis. The two things is what we call vertebral rotation. It's not just a side-to-cycle. The spine is rotating like a spiral staircase, which is why the ribcage pushes the scapula outward. Next, I will schedule some further examinations to confirm your exact condition. To get a clear picture of what's happening with your spine, I would like to perform a formal Adam or vein test and take X-ray from various angles.
Does it hurt?
No, not at all. I just need to observe the alignment of your back from behind while you bend forward. Okay, so now please come here. Please stand with your feet straight and your knees together. And now put your waist together and as if you are about to dive in. Now slowly bend forward. Pull your toes. Alright. Perfect. Stop right there. Okay, so this is called a rib pump. It is the most critical sign of structural scoliosis. So now I'm going to use sclerometer to measure the angle of trunk rotation.
Look here, this is the seventh cervical vertebra, also known as vertebral prominence. It serves as the starting point for measuring scoliosis. Under normal condition, the spine should align linearly along the median furrow, maintaining a straight midline trajectory. In patients with scoliosis, however, this alignment is disrupted with a clear rightward deviation of the median furrow at the thoracic. Next, we examine both scapulae. The right scapula is not only positioned at a higher level, but its medial border also rotates outward. This finding is attributable to vertebral rotation, which causes the underlying rib to protrude posteriorly and elevate the scapula. Turning to the lumbar region, the skin creases at the waist are asymmetrical. This asymmetry suggests increased tension in the quadratus lumborum muscle and is indicative of an associated pelvic tilt. So the asymmetry we've just observed at the surface, such as uneven shoulder height and rib prominence, are merely superficial manifestation. To understand the origin of this visible change, it is essential to look beyond the skin and examine the underlying osseous structure. First, we consider the vertebral bodies. In the normal spine, the vertebral column should be perfectly aligned in a straight line when viewed from the coronal plane. Over time, due to the asymmetric loading, vertebral bodies undergo deformation and become wedge-shaped, resembling compressed building blocks. Furthermore, why does the posterior thoracic region appear prominent? This relates to the mechanism of vertebral rotation. Scoliosis is not merely a lateral deviation of the spine, like bending a ruler. It is also accompanied by axial rotation of the vertebral body. Imagine the spine as a column made of stacked building blocks. When the spine bends to the right, each vertebra simultaneously rotates toward the convex side of the curve, because the ribs are attached to the thoracic vertebrae. When the thoracic vertebrae rotate toward the right and posteriorly, like turning a steering wheel, they push the ribs on the right side backward. That's why the patient's right posterior back appears more prominent from an external view, which is referred to as rim hump. It is worth noting why the curvature tends to occur toward the right rather than the left. This involves deeper visceral anatomy, because the heart is located on the left side, and the aorta also occupies the left thoracic region. This structure creates spatial constraints. As a result, when the spine undergoes lateral displacement, deviation toward the right becomes the path of least resistance. This explains why the majority of adolescent patients present with a characteristic right thoracic scoliosis. This asymmetry propagates downward along the axial skeleton. When the sacrum becomes tilted, it consequently affects pelvic alignment, resulting in unequal height of the iliac crest. This explains why some patients with scoliosis appear to have a leg length discrepancy. In reality, it is due to pelvic obliquity. The scapula are also displaced as a result of thoracic cave deformation, leading to asymmetry in shoulder height. In some cases, the scapula may become prominent, even appearing wing-like. In addition to osseous structure, muscular chains must also be considered. Under normal condition, the erector spinae muscle on both sides of the spine functions symmetrically. However, due to the spinal curvature, the muscle on the convex side, or we call it the right side, are displaced and excessively elongated, giving them a more prominent appearance, whereas the muscle on the concave side, or we call it the left side, becomes shortened and tight. Furthermore, the deep transverse spinalis muscle group, including the multifidus and rotatoris, also loses its ability to stabilize the vertebral column, making the curvature more prone to progression. Over time, this muscular imbalance can lead to increased fatigue and may even impair physical performance. At the lumbar level, the contractus lumbarum on the concave side become markedly tight, eleving the pelvis. Meanwhile, asymmetry in the length of psoas major, which connect to the femur, can affect gait stability during running and physical activity. Even the anterolateral abdominal muscle, involving respiration, namely the internal and external obliques, become asymmetric due to trunk rotation, making patients more prone to shortness of breath during exercise.
Okay then, I think we can do the X-ray for the further test. Alright, let's take a look at your lateral view X-ray. Based on the image, we can see that your exoskeleton is normal physiologic curvature. You have a very noticeable flat back, which is a common finding among patients with scoliosis. Next, let's move to your anterior posterior X-ray. To measure the severity of the curve, we first draw a line along the superior endplate of the top vertebra of the curve, and another along the inferior endplate of the bottom vertebra. The intersection of these lines gives us the top angle, and your angle is approximately 28 degrees. According to clinical grading, this falls into the moderate category, which means you may need to consider bracing in the future. Finally, let's examine your razor sign. Based on the degree of calcification in your iliac apophysis, I will press you at a razor tube. Clinically, this indicates that you are currently in your peak growth spurt, meaning the rate of progression remains high. Combining these two indicators, I would define your condition as having a moderate probability of progression. We believe you will need to wear a correct lens in the coming months to provide external support for your spine. This is especially critical for adolescents whose skeleton are not yet fully matured. We will also supplement this with some physical therapy.
To effectively manage scoliosis, we rely on the Cobb angle, the clinical gold standard that dictates our treatment path. Understanding this scale is crucial, as scoliosis treatment is essentially a race against degrees. First, an angle under 10 degrees is considered normal. In clinical terms, this is spinal asymmetry rather than scoliosis. Our strategy here is simple. Observe with periodic checkups to ensure no progression occurs. Once the curve exceeds 10 degrees but stays under 25, it enters the mild category. Our goals remain observations, monitoring the patients every 6 months. However, we stay alert. Hitting the 25-degree threshold is the signal to escalate care. The moderate stage occurs between 25 and 45 degrees. Here, observation is no longer enough. The standard treatment is a brace. The primary goal is not to fix the spine, but to lock the curve in place and prevent it from worsening during the adolescent growth spurt. Finally, any angle greater than 45 degrees is classified as severe. At this magnitude, the curve often progresses even after growth stops, potentially impacting lung functions or causing chronic pain. Therefore, the recommended treatment is a surgery, typically a spinal fusion to realign and stabilize the spine. There is a sign. By looking at the ossification of the iliac crest, the top ridge of the pelvis, we can determine exactly where Maya stands in her growth journey. Currently, Maya is at stage 2. This means the bone hardening has covered about 25% to 50% of her pelvic ridge. In clinical terms, Maya is right in the middle of a peak growth spurt. Her spine is elongating rapidly, which means the risk of a 28 degrees curve worsening is still extremely high. To put this in perspective, the risk scale goes from 0 to 5. The lower the stage, the higher the danger, because there's more growth left to fill the curve. As Maya moves towards stage 4 and 5, her bones will fully harden and fuse, and only then will the wrist finally stabilize. But right now, at stage 2, Maya is in critical window. Her bones are still soft enough to be guided, but her growth is aggressive enough to cause trouble. This is why we can't wait. We must use a brace now to protect her spine before she reaches fully maturity. With both metrics, we can address the core questions. What is the risk? Management isn't about one number. It's about the interaction between curve magnitude and remaining growth potential. For mild curves, the risk depends entirely on maturity. At RISA 2 to 4, the growth is slowing, keeping the risk low at 5% to 15%. However, for a RISA 0 or 1 patient, the same curve jumps to a 40% risk, simply because their growth engine hasn't even hit its peak phase yet. This brings us to moderate curves, the category of Mayas fall into. Here, the data becomes alarming, while those with low growth potential face a moderate risk. For those at RISA 0 or 1, the probability of progression skyrockets to 70%. This is why we don't wait and see for an immature patient. Once we enter severe curve, the risks are very high regardless of maturity. Even with low growth potential, gravity and biomechanical instability create a 40% to 70% chance of worsening. The most dangerous scenario is a SURF curve at RISA 0 or 1, where progression is statistical certainty at 90%. Without aggressive intervention, this deformity will become life-altering. Ultimately, this metric gives us protective power. A high angle plus high growth potential is a medical emergency. In Maya's case, at around 28 degrees and RISA 2, her risk of progression is over 40%. This is our call to actions. By intervening today, we change her statistical future, guiding her away from high-risk surgery and toward a stable, healthy maturity.
Alright, that concludes our consultation for today. I hope your treatment goes smoothly and wish you the best of luck. And here is candy for you. Good luck.